I'm Dr. Joe Green. I am the medical director for bariatric surgery here at Reston Hospital Center. I'm a board certified general surgeon and a fellowship trained bariatric surgeon, which means I took an extra year after my general surgery training to study specifically bariatric and foregut techniques in minimally invasive surgery. And we're here to talk about safe and effective weight loss for life. I usually start this webinar by asking everybody to kind of think and reflect why they're here. And I get to take a chance to tell everybody why I do what I do. It's for her and for him and for her and for her and for her and for her and all these wonderful people that I get to share this amazing life transformation journey with. And I know we came to talk about surgery, but for a second, I have to lay out that the success in bariatric surgery is really based in the bariatric lifestyle, way much more than the surgery. And the bariatric lifestyle incorporates things like high protein, low carbohydrate nutrition, regular physical fitness, being part of a community. If you look around, there are other people that are starting this journey and people that are on this journey with you. And mind and body wellness, our mental health care can't be ignored. It's so important in some of these trying times that we're in. And yes, there's a surgery that's involved, but I like to tell people that while the lifestyle is what we do every day, before and after surgery, the surgery is just one day of your life. The lifestyle is way more important. So, what does a bariatric nutrition program look like? It's based in proteins and vegetables, things like poultry, fish, eggs, lean dairy, tofu, meat if you eat it. Why? Because these things absorb slowly. Think about the last time you had a steak dinner. You felt full until the next morning. And our enemies in this journey are the carbohydrates, the bread, rice, pasta, potatoes, cereals, fruit, and the crunchy snacks that come in silver cellophane lined bags, that entire aisle of the grocery store. Those things cause our blood sugar to rise and insulin, and quickly a hunger cyclic cycle starts. Kind of imagine if you had a bag of potato chips for a snack. You were very quickly felt full, but then again, quickly hungry again. So, who's been told by their doctor to just diet and exercise their way from obesity? And it's unfortunate because that person didn't really understand all the math behind this, right? Calories are just energy, like fuel for our car. And there are only three sources of macronutrients in our diet: protein, fat, and carbohydrates. Protein and carbohydrates have 4 calories per gram, while fat has 9 calories per gram. That's why our body uses fat to store energy because it's efficient. But if someone wants to lose a pound of fat, they have to lose 380,000 calories. And if someone wants to lose 100 pounds of fat, they have to lose or burn 380,000 calories. And now strenuous exercise is great because it burns, give or take, 10 calories a minute. Um, but suffice it to say, it's going to take a long time. So the way I frame this conversation is that reduced caloric intake from surgery helps to induce a rapid weight loss. And while we're going to be practicing a physical fitness program along the way and exercising once we achieve our goal weight, helps account for a couple hundred calories a day in caloric intake differences per day. Now, you may have heard your doctor talk about the BMI, the body mass index. It's not meant to be judgmental. It really is just an equation that corrects our weight for height. It's kilograms divided by meters squared. So it doesn't penalize taller people for weighing more. And the reason that doctors talk about BMI, though, is because as the BMI goes over 27, the risk of contracting disease related to obesity and dying from those things starts to increase. And why it's so alarming to me as a bariatric surgeon is that you can think of our American population in roughly three segments. Roughly one third that has a normal weight BMI, that's from 18 to 25. Another third that has a BMI of overweight from 25 to 30. And it's actually closer to 40% now of the American population that suffers from obesity, which is a BMI of 30 or more. And it's very quickly rising compared to other things that kill people, whether we smoke tobacco products or not. I think we would all agree that smoking tobacco is bad for our health. And that's because a large public health campaign that the government ran for many, many years increased awareness of the dangers of smoking and the risk of dying from smoking. And so that's quickly declining, while for obesity, it's still rising. If we compare it to common cancers, Breast cancer and colon cancer together are only killing a third of the people that obesity is killing. But I would also submit to you that there's a conversation happening about, for example, breast cancer. It was just October is Breast Cancer Awareness Month. Susan G. Komen has a foundation. There's a walk from breast cancer. People wear pink ribbons and pink wristbands. There's a conversation happening about breast cancer treatment that's not happening about obesity treatment. So, part of what we're here to do tonight is to have a non stigma, non biased, very simple conversation about safe and effective obesity treatment. What causes obesity? There are many things. It's not a lifestyle choice, it's not a willpower issue. It really starts with our genes. There are many different genes that have been associated with weight gain, hundreds. The most commonly studied one, MC4R. But suffice it to say, you may notice that there are some families where more people suffer from obesity than other families. There are physiologic causes. Those genes play into how our metabolism works. There's stretch receptors in the stomach that we can change with surgery. There are behavioral causes, certainly family traditions. My running joke on this webinar is about Thanksgiving. Thanksgiving is one of the biggest holidays of the year for my family. We gather aunts and uncles and cousins and grandparents and babies that were born, and we meet up at someone's house, and we get to share stories and meet the new babies and the new spouses if we couldn't attend a wedding, and we share a festive meal. But if you look on the Thanksgiving dinner menu, what is there? There's stuffing and mashed potatoes and gravy and cornbread and a pasta dish of some kind. Maybe the only protein is the turkey. And so, while every culture has these family traditions, sometimes the things that we're serving in them aren't as conducive to weight loss as we'd hope. There's psychosocial causes, and I think the societal cause is really interesting, particularly to me, the way technology has changed human society. So if you close your eyes for a minute, think back thousands of years when humans were hunter-gatherers. We lived in caves or villages, and the only way we could get a meal was to go and find it. So the people that were strong and able-bodied, they would walk for hours or days to hunt a buffalo or an elephant, depending on what continent you lived on. They'd have to wrestle it to the ground and kill it and carry it all the way back to their camp. While the people who couldn't travel or were too young, they would go to the fields around where they lived and they would pull up roots and grow vegetables. And they'd meet back at a campfire and they would roast it over. And at its core, what they were consuming was the protein from the animal and the vegetables that they grew or that they found. I know. So fast forward now to 2024, or really, I think the pandemic brought this out a lot. We were all in lockdown. How did we get a meal? You pick up your phone, DoorDash, Uber Eats, Grubhub, right? They would bring the meal straight to us. And what was the meal they were bringing? Maybe it was pizza or sandwiches with all the bread, carbohydrates, right? Or Chinese food, noodles, pasta, rice, right? More carbohydrates. So if you think that our body was designed to spend a lot of energy to obtain a meal of protein and vegetables, and now we spend no energy for a meal of carbohydrates, we flip the whole equation on its head. And along with the other things that I put here, I think that's what causes obesity. And the risk is pretty significant. As the BMI goes over 30, we have a 55% increase in mortality, dying from anything. A very strong link with coronary artery disease, heart disease, and cerebrovascular disease, stroke, and a very, very strong link to diabetes. Young men are particularly high risk, and it's hard to think that a third of us may not reach the age of 65 unless we achieve safe and effective obesity treatment. At Reston Hospital and my practice, you're going to find a compassionate environment where we take care of people who have difficulty going to the movies and finding a seat in the theater, or finding a seat on the bus, or using the seatbelt extender on the airplane, maybe passing through that narrow turnstile on the metro. Certainly, it's hard to run around and play with our kids, and certainly designers don't make all of the sizes of clothes that some of our patients are looking for. So at Reston Hospital, at our practice, you're going to find a safe space where we believe that obesity is the last holdout of discrimination in our society, and we're here to have a non-stigmatized, non-biased conversation about how we can treat it effectively. But For a second, I want to stop and talk about the medical implications of obesity. Now, when doctors go to medical school, we specialize, like I'm a bariatric surgeon. But if you have a skin condition, right, you see the dermatologist. If you have a GI problem, you see the gastroenterologist. And I would submit to you that there's not a specialty of medicine or organ system represented here that isn't affected by obesity, right? Cardiologists treat high blood pressure, high cholesterol, heart disease. Pulmonologists, lung doctors treat asthma, sleep apnea. Endocrinologists treat type 2 diabetes. Gastroenterologists treat non-alcoholic steatohepatitis, fatty liver disease, which is quickly replacing alcoholic cirrhosis as the leading cause of liver failure in this country. Heartburn, gallstones, orthopedic surgeons treat arthritis, gout, back pain. Gynecologists treat women who suffer from infertility and menstrual irregularity at higher rates when they have obesity, and also a higher risk of obstetric complications. If they deliver vaginally, women are a higher risk of urinary incontinence, leaking urine when they cough or sneeze or laugh. I mentioned hematologists and oncologists treat cancer. There's so much research being published in medical journals every month about the increased risk of certain types of cancers in people who suffer from obesity. And interestingly enough, when they have bariatric surgery and bring their weight back down to a normal BMI, their risk of cancer returns to that of the average population. The best part is that bariatric surgery and significant weight loss can reduce our risk of developing all of these things, improve them if you already have them, and maybe even make them go away altogether, which would be great. So, how do we treat obesity? Well, all right, that doctor who said diet and exercise, that person wasn't entirely wrong. They just didn't get the whole picture, right? Research will show that an intensive lifestyle intervention, that's what we call it, of coaching someone with nutrition and fitness will help them to achieve about 5% weight loss, which is fantastic. Except if I meet someone who's at 300 pounds, for example, and tell them that I can get them to 285, well, it's great. A lot of people want more than that. I used to say that the pharmacotherapy medications like phentermine weren't very powerful, but some of the new injectable drugs actually have very strong and effective data behind them. The problem is that the newer studies, as we see them become more woven into medical practice, when people stop some of those injectable medicines, the risk of gaining much of that weight comes back. And I'll take a second to mention open bariatric surgery. We only do minimally invasive bariatric surgery here at Reston Hospital, but it did lay the foundation for what we know about the effectiveness of bariatric surgery in obesity treatment. So, right, I mentioned there was a time when people got split stem to stern through a big incision. Surgeons put their hands inside of people to do the cutting and the suturing of the surgery, and it resulted in an unacceptably high complication rate and a long hospital stay, and that's all over. I mentioned we only do laparoscopic or robotic, minimally invasive bariatric surgery through small incisions, about a quarter inch to a half an inch in size. We pass long, thin instruments through the abdominal wall so the tips are much finer to do the cutting and the suturing of the surgery. It results in much less pain. A one night stay in the hospital, if that. Some people are going home the same day, and people bounce back to work pretty quickly. I'm proud to say that I offer robotic bariatric surgery in my practice. Now, it's done through the same small incisions. The only difference is that this white machine here, that looks like an octopus, this is the surgery robot, and all it does is hold the instruments and mimic the movements of my hands. So I sit here as the surgeon at a desk that we call a console, and when I look inside there, the advantages of robotic surgery are that I have a three-dimensional immersive view of the abdomen with incredible zoom. I can use fluorescence imaging for guidance during surgery. And like I said, is all it does is scale down the movements of my big hands down here into precise millimeter movements in the abdomen. I know what you're thinking. Well, where's the button that you push it does the surgery? There's no automation. It's not like a self-parking car. The surgeon commands the robot at all times. And in fact, when the surgeon removes their head from this console, from the viewer, everything is frozen. The robot does nothing on its own. So the objectives of bariatric surgery then are to improve our health, improve our quality of life, increase our lifespan. This is not cosmetic surgery, but sometimes treatments have a positive side effect that we can also enjoy as well. But what I really want to hone in on are the criteria that most insurance companies will adhere to for approving bariatric surgery. Despite the guidelines being more than 30 years old, they were established at a consensus conference at the National Institutes of Health back in 1991, where a bunch of experts got together and said that at a BMI of 40, someone's health was at such risk because of obesity that they should have bariatric surgery. And even at a lower weight, even at a lower BMI of 35, if someone's obesity was manifesting a disease like diabetes or sleep apnea or high blood pressure that will one day take their life, that person should also have bariatric surgery. Now, over the years, there were some newer devices that gained expanded indications, and they said that people should have a history of being part of a supervised weight management program. That'll be the foundation for the number of months or visits that we do together here in my office in preparation for surgery. They also said that people should have the tools from a nutrition standpoint to support their new lifestyle, and that's the requirement to have a nutrition clearance. They also said that people should be free of other things from a mental health standpoint that are preventing them from engaging in this big life decision. And that's why it's also a professional society guideline recommendation and an insurance requirement that people have a mental health clearance before engaging in this big life journey. Now, there are some insurance companies that have adopted lower guidelines, such as HCA, which drop those BMI numbers by 5 each, although it hasn't been widely adopted amongst the commercial carriers. So that we can understand how the surgeries work, I'm going to do a quick anatomy 101 review of how we look inside right now and how that changes with surgery. So tonight when we eat dinner, food is going to go down our mouth and down our esophagus into this big bag looking organ called a stomach. And the stomach just has acid that helps the food to break down to its basic building blocks. And as the stomach fills up, it has stretch receptors in this top part, the bulbous part called the fundus, that as they stretch out, send the signal to the brain that we're full. The problem is that they're on a delay by about 20 or 30 minutes. And anyone who's, for example, had a second helping of Thanksgiving dinner and 30 minutes later felt a little too full and said, I probably shouldn't have done that, knows exactly what I'm talking about. It's a problem that's inherent with the stomach, that it can fill past the point of satiety before the brain knows it. And we can change that with surgery. Once the food leaves the stomach, it goes into the small intestine. That's this narrow tube that wraps around the middle of the belly here. And that's where all of the absorbing of the macronutrients, the proteins, fats, and carbohydrates, as well as the micronutrients, the vitamins and minerals, happens. Now, once all the nutrition has been extracted from the intestinal content, it's dropped into the colon or the large intestine. And that's this one here that wraps around the sides of the abdomen. And the job of the colon is really just to remove the moisture from the contents of our intestines so that it comes out as solid stool on the other end. Now, if you're asking why I went into such detail, it really is to highlight that the stomach really is just a reservoir. It holds food in preparation for digestion, and the colon just removes the moisture. All the absorbing of vitamins and minerals, the micronutrients, as well as our macronutrients, happens here in the small intestine. It's a magical organ for a GI surgeon. But with that foundation, we can talk about the sleeve gastrectomy, the gastric bypass, and the duodenal switch. When we do a sleeve gastrectomy, you may also hear it referred to as a VSG, a vertical sleeve gastrectomy, because the stomach is divided vertically, and the extra part, that bulbous, that fundus that used to live over here, is removed. And what that does is it takes away most of the cells that make ghrelin, or the hunger hormone. They used to live up here in the fundus. And so people wake up from surgery feeling no hunger. And it leaves many fewer stretch receptors in the stomach. So this new stomach that holds about 2 to 3 ounces of food, when the first ounce goes here and the second ounce goes here, as it fills up the third ounce, there's no big place for it to stretch out to anymore. It very quickly sends the signal to the brain that we're full. So it gives a great sense of restriction and a very low risk of hypoabsorption because the intestines that absorb the vitamins and minerals have been totally left intact. This is actually a view from surgery. I want to show you what amazing detail we get to operate in. This is a sleeve stomach here. The extra part has been removed. These are our instruments. This is about a 1/4 inch in size. This is a needle and thread like you would sew a button back on your clothes with. And this is the surgical staple line where we divide the stomach. I want to say this is a technique that I'm very proud that my mentor taught me and that I do in each and every one of my sleeve surgeries. So this staple line is what presents the risk of leaking and bleeding from the surgery. And what we do is I sew a French seam from one side back and forth to the other. What that does is it imbricates or folds inwards the staple line of the sleeve so that the new stomach has no staple line visible. And what this has done is it's dropped the risk of leaking and bleeding complications in my practice virtually to zero. If you're wondering why everybody doesn't do this, well, first, it's a difficult technique to master, and it takes about 10 or 15 minutes longer every surgery that I do. So while I may not be the fastest sleeve gastrectomy surgeon in the world, I'm going to do everything in my power to make sure that you have the highest chances of success and the lowest risk of complications from the surgery if this is the one you choose. This young lady, you feel free to reach out on Instagram. She had a sleeve and would love to share all the success in her journey with each and every one of you. But so we can have a fair, balanced conversation about the surgeries, we'll do a little pro and con of how they work and the advantages and disadvantages of each. So the advantages of sleeve are that it's great for patients that have complex bowel conditions like Crohn's or lupus or adhesions from prior surgeries, or that need complex medications that could be put at risk the connection of, for example, a gastric bypass. The disadvantages are that long staple line that we mitigate with our sutures. It can't be reversed. That part of the stomach is removed. It goes to a pathology lab for examination. And for anyone who wants to start a family, they have to wait 1 year after sleeve gastrectomy, gastric bypass, or duodenal switch. There's just not enough nutrition to grow another life inside of you. So this is what a gastric bypass or a Roux-en-Y gastric bypass looks like. It combines restriction and hypoabsorption. Restriction because we take the old stomach and make a new small stomach up here that holds about 2 ounces of food. And then this intestine, small intestine, used to be connected here. We divide it and we sew a new connection here so that the food goes down this way and it bypasses the old stomach, hence gastric bypass. And it meets up with the digestive juices here coming on down. Now, gastric bypass is the oldest operation that we have for bariatric surgery. It was done even in the days of open surgery. And so we know from the long amount of data that we have about it that it has an excellent resolution of things like diabetes and heartburn for people who suffer from those things in addition to their weight. And also that people have to take some extra vitamins to maintain good nutrition. I'm going to tell you a story about Joe. Joe used to work in the operating room with me, handling our instruments, and he saw these people, my patients, having amazing life transformations, and he said, I want to do that too. So Joe had a gastric bypass, and now he loves going to the gym. He sends me pictures on his Instagram. You can connect with him as well when he's going on trips and not using the seatbelt extender, and he's really living his best life because of his gastric bypass. The advantages of gastric bypass are rapid and durable weight loss, with particular resolution of things like diabetes and heartburn. And it's the second most common operation being performed in the United States today, second to sleeve gastrectomy. I mentioned the disadvantages that one, you're waiting to conceive if someone wants to lose weight and have a child. It's stomach and bowel surgery, so it's a bigger surgery, a little bit more risk involved, and extra vitamins to maintain good nutrition. This is a duodenal switch, and you may hear it referred to by a number of names, the DS, the SADI, or the loop duodenal switch, because all it is really a sleeve gastrectomy on the stomach here, and then a second part where the first part of the bowel called duodenum is divided, and the bowel is looped around, and a connection is made here between the duodenum and the last part of the bowel called the ileum. So it's both a restrictive and a hypoabsorptive operation. And it has the best weight loss and the best resolution of diabetes of any surgery that we do. But again, a couple extra vitamins to maintain good nutrition. You may have also heard about the biliopancreatic diversion with duodenal switch. I won't bore you with the anatomic details, but suffice it to say there were two connections in this old version of the operation, one and a second one here. The operation was updated in 2020 to its current configuration, which we call SADI, because single anastomosis duodenal ileal bypass with sleeve gastrectomy is more of a mouthful than most people want to say. And again, it's as a sleeve surgery like we talked about before on the stomach, and then the bowel loops around and one connection is made here. This is a friend and a patient and a colleague of mine who had a SADI and would also love to share her experience and her success with you. feel free to reach out. The advantages of SATI are that it has the best weight loss and the best resolution of diabetes of any of the surgeries we talked about. And it can be performed in 1 or 2 stages to fit somebody's needs. So, for example, we can do the whole operation, both parts, the sleeve part and the duodenal part, at the same time. Or if someone wants to have a sleeve, for example, to lose weight and have children, or have a knee replacement, they can come back years later if they want and have the second part done. So it can be customized to a specific person's needs. I mentioned again the disadvantages of waiting a year to conceive. Now it's stomach and bowel surgery with a bigger bit of dissection than a gastric bypass and a few more vitamins to take. But the common themes with any of these operations are that we're going to focus our meals on high protein and low carbohydrate meals containing vegetables. The capacity of the stomach is going to go way down, about 3 ounces of food per meal. Too much is just going to make us uncomfortable. In conclusion, I believe that obesity is a chronic medical illness caused by multiple factors, and it has far-reaching health consequences, and that metabolic and bariatric surgery really is the only tool for sustained and effective long-term weight loss and resolution of those medical conditions. So what's next? Feel free to get involved in the community part of the bariatric lifestyle I mentioned earlier. You can find me on Instagram. I'm Dr. Joe Green. I have a YouTube channel if you want to see more about the surgeries and how they work. We can kind of demystify the operating room. We have a very active Facebook page, and I use Peloton for my personal fitness program. And my Peloton handle is the same as my Instagram handle, Dr. Joe Green. That's where the Greens Machines hashtag got started. That's our fitness team. Anytime we're exercising, we put that hashtag up to support one another in our fitness programs and our fitness journeys along this healthy bariatric lifestyle. But you're probably wondering how to get ready for surgery. It's going to start with an office visit. We'll get together. And in the meanwhile, I'd like you to record a history of the diets that you've done in the past. We're going to write that in your chart as evidence to why the insurance company should approve your surgery, given all the things you've been trying to do already. I mentioned the insurance requirements earlier, the requirement to have nutritional counseling, mental health evaluation, and documentation in the chart of what you're doing for exercise training. We're going to make a medical testing and clearance plan specific for you. So for example, if you have risk factors for sleep apnea, we'll get you tested. If you already have a diagnosis of sleep apnea, that's fine. We're just going to ask for a copy of the report that diagnosed you so that we can make sure the CPAP is set appropriately when it comes time for surgery. Something special in my practice is I ask everyone to write a personal letter about why they want to have their surgery and its risks and its benefits. And we can give you some more information on that when we get together in the office. So with that, I'm going to stop sharing my screen and open up the floor for questions.